Thank you all for coming. I'm so glad you're here. Go ahead and filter on in and sit down. We're here to listen to a wonderful speaker, Dr. Suzanne Wetgerold, which I've never heard before. I'll try not to butcher it. She is an internal medicine doctor, cardiologist, works in the field of echocardiography and nuclear cardiology, and has this interest in weight management because it affects all of us so tremendously in our lives, whether it's us or a loved one or just our future of needing weight management. It affects all of our dollars of care, our quality of life care, and how long we live. So we're going to, I've asked Dr. Wetgerold to kind of crunch it down where there'll be plenty of time for questions and answers afterwards. And a lot of those questions and answers are things that people who will look at the portal later would have loved to have asked. So we invite all questions. Wellness Committee is really excited to have her here. And if everyone will turn off their ringer on the cell phone, we will go ahead and get started. Thank you.
Thank you. Thank you for that introduction. So yes, I'm a cardiologist with Austin Heart, but I'm also board certified in weight loss medicine. It's always been a particular area of interest of mine to try and treat people with lifestyle rather than just more and more medications, which a lot of patients appreciate. So this is normally about an hour talk, so I've whittled it down. I'm going to try to get through it in 30 minutes so we have some time for questions. All right, so as most of you know, I'm sure the prevalence of obesity has increased dramatically over the decades, and it is projected to continue to do so. So the estimate is that by 2030, 50% of the population will be suffering from obesity, and another 30% will be suffering from being overweight. So roughly 80% of the population by the time we hit 2030. So since 1980, obesity rates have doubled in adults and more than tripled in children. 112,000 obesity-related deaths each year in the U.S. So this is more than, we all hear about the narcotics epidemic, fentanyl. This is killing more people than narcotics. Overweight and obesity-related illnesses are the second leading cause of preventable death in the United States, second only to smoking. And obesity is projected to overtake smoking as the leading cause of cancer in the U.S. So as of today, from the CDC data, 44% of American adults are obese and another 30% are overweight. 20% of American children are obese and another 14% are overweight. And obese children are twice as likely than non-obese children to die before the age of 55. And this current generation of kids is expected to have a shorter lifespan than their parents by 3 to 5 years because of the risk of obesity. 33% of young adults are not qualified for military service due to their weight. So the impact on our lifespan, obesity is responsible for 4.7 years of life lost for the average person suffering from obesity. And if we break that down a little bit better, a body mass index, which is your weight indexed to your height, body mass index of 30 to 35 is associated with roughly 2 to 4 years on average of life lost. And if we go to a body mass index of 40 to 45, it's associated with shorter lifespan by 8 to 10 years. And by comparison, smoking is responsible for 4.3 years of life lost for the average smoker. So in terms of the financial cost, the per person annual obesity-related healthcare costs are estimated to be almost $4,000 if the body mass index is 30 to 39, and we go up to almost $10,000 for a body mass index of greater than 40. And in the U.S., as a country, we could save $600 billion in healthcare spending by 2030 if the average body mass index was reduced by 5%. So with very small improvements, we get huge benefits, not only for our health, but as a society. estimated annual US healthcare expenditure for obesity is $200 billion. And then there are billions of costs associated with missed work days and reduced labor force. So here's how those extra financial costs break down. So patients who suffer from obesity spend on average 28% more in outpatient medical costs, 45% more in inpatient medical costs, and 80% more in prescription drug costs. So here's just a few specifics about the health conditions associated with obesity. So for every 1 unit increase in the body mass index, and that equates to about 6 to 7 pounds. So for every 6 to 7 pounds of weight we gain over a normal body mass index, there's a 4% increased risk of atrial fibrillation, 6% increase in congestive heart failure, 6% increase in hemorrhagic stroke or bleeding type strokes, 4% increase in ischemic stroke, 7% increase in gallstones, and obesity is the most important risk factor for high blood pressure, type 2 diabetes, and sleep apnea. So what I find in my patient population is that most people don't realize that obesity is a significant risk factor for cancer. But adipose tissue is not inert. It secretes lots of inflammatory markers, it secretes hormones, and those things increase our risk of cancer. So these are several cancers where the risk increases substantially in the setting of obesity. So endometrial is a 7 times higher risk, esophageal 4 times higher, stomach cancer twice the risk, liver and kidney twice the risk, pancreatic cancer 50% higher risk, colon cancer 30% higher risk, gallbladder cancer 60% higher risk, breast cancer for postmenopausal women 20 to 40% higher risk. And for thyroid cancer, multiple myeloma, and ovarian cancer, there's a 10% higher risk for every 5 unit increase in body mass index, which equates to about 30 to 35 pounds gained. So the good news, as I mentioned, is that for very small improvements in weight, we get huge benefits. So for 5 to 10% weight loss, so if somebody weighs 300 pounds, 15 to 30 pounds of weight loss, there's a 50% improvement in sleep apnea, on average a 10-point decrease in the systolic blood pressure, which is as much as we get with 1 to 2 blood pressure medications. So at 10% body weight loss in our clinic is when we can generally start reducing the blood pressure medications. An improvement in the cholesterol panel, a 50% decrease in risk of type 2 diabetes. So your risk of becoming diabetic is cut in half if you can lose 5 to 10% of your body weight. And a significant decrease in the atrial fibrillation burden. And I'm going to show you some more about atrial fib. Extremely common, and we'd venture to guess there are probably people in this room who have atrial fibrillation or a history of atrial fibrillation. So this was a very important trial called the Legacy trial. So there were 355 patients. You had to have a body mass index of 27 or greater to be included in the trial. All the patients were offered either a self-managed weight loss program where they just did their best on their own and had some phone calls of encouragement, or a comprehensive physician-led weight management clinic. Of the people who achieved 10% body weight loss, 84% of those people participated in the physician-run program as opposed to the self-managed program. And of the people that maintained that weight loss at 4 years, which is the really difficult part, and I'll get to some of the reasons why that is, but 85% of those people attended the physician-run program. So this was the big result of the trial, was that weight loss of greater than or equal to 10%. So again, for somebody who weighs 200 pounds, we're talking about 20 pounds. 300 pounds, we're talking about 30 pounds. That resulted in a 6-fold greater probability of arrhythmia-free survival, meaning no atrial fibrillation, as compared with those who lost less than 10% of their body weight. And that 6-fold greater probability of no more atrial fibrillation is vastly better than we can do with medications. All right, so how did we get here where everybody's struggling so much with their weight? It's not a mystery. We know what happened. It was several factors. The abundance of cheap calorie-dense foods that are lacking in nutrition, including ultra-processed foods, which I'll talk a little bit more about. Increased portion sizes, so we all know the plates have gotten bigger, the bowls have gotten bigger, everything's gotten bigger. Portion sizes in restaurants. Poor sleep health, which I'll talk a little bit more about. There's a very strong correlation between sleep and weight. Lack of physical activity, increased workload, increased stress and decreased leisure time. Medications and polypharmacy, so there are lots of medications that can cause weight gain, some of the antidepressants, steroids, we all know steroids can add weight. Environmental factors and the gut microbiome. The gut microbiome, I could do a whole hour talk on that, but it's basically all the flora that live in our gut that help us digest our food. And the populations of gut flora that we have are determined by the foods we eat. So it turns out that people who suffer from obesity tend to have certain populations of gut flora. People who don't suffer from obesity tend to have other populations of gut flora, and interestingly, if you transplant the gut flora from one patient to another, they will lose or gain weight depending on the donor. So again, that's a whole other talk that's fascinating to me, but we'll get into that. Okay, so this was a big one. The 1977 dietary recommendations from the United States government to reduce the fat in our diet, right? Low-fat diet. The official recommendation was to reduce the total fat consumption to 30% of the diet, 30% of the calories, and saturated fat to 10%. Those recommendations had not been tested in any single trial before they were released to the public. And Dr. Robert Olson famously pleaded with Senator McGovern for more research on the problem before we make announcements to the American public, and McGovern replied, "Senators don't have the luxury of waiting until every last shred of evidence is in." So this is what happened when those recommendations came out. If you look at this first slide over here, that line on top is carbohydrate intake in grams per day. And where it ticks up is at 1977. So people did what they were told, right? They reduced the fat in their diet, but they didn't reduce the calories. So those calories have to come from somewhere. Well, they didn't increase protein, they increased carbohydrate, largely in the form of highly processed foods, highly refined grains, and added sugars. And if you look at this second chart, that's macronutrient intake, meaning carbohydrate, protein, and total fat as a percentage of energy intake. And you can see there, that line in the middle is fat, and that went down at 1977, and the carbohydrate went up. And I know everybody talks about carbohydrate now and low carb and keto and all these things. The issue with carbohydrate is that that is our body's first choice for fuel. Our bodies will always choose carbohydrate before it will turn to body fat as its fuel for the daily metabolic needs. So if we are feeding our bodies enough carbohydrate to meet our energy demands, we will never have any reason to burn fat. So an excess of carbohydrate just makes it very easy for our bodies to store body fat. So, sugar consumption. If we look at the 1800s, right, sugar was a delicacy. And then it became cheaper and more available. And then you hit around 19-teens, around World War I, and then World War II, it kind of leveled out. And then that red line is where the 1977 dietary guidelines came out. And you can see there was a significant uptick in the sugar consumption in the US. So I don't know if you all remember, I do, the fat-free, everything fat-free, low-fat. What they did was take out the fat and add sugar. So I tell my patients, if it says low-fat or no-fat, most likely you should just keep walking. You're better off with the fat. So this is what Americans are buying in grocery stores. This is the typical American diet. 12% plants, which that should probably be more like 50 to 60%. 25% animal products, that's about right. And 63% processed foods that contain added sugars, refined grains, preservatives, and artificial sweeteners. And this is believed to be one of the contributors to colon cancer being seen at younger and younger ages, right? The age for the recommended first screening colonoscopy just dropped from 50 to 45 because we're seeing so many more cases of colon cancer in younger patients. So this was a study on ultra-processed foods, and I'm going to show you what those look like in a minute. This was a great study. So they took 20 people, and they had them in a facility, so they couldn't eat anything other than what they were given. And they divided them in half, so 10 adults got trays, breakfast, lunch, and dinner, that were ultra-processed foods. The other 10 people got trays for breakfast, lunch, and dinner that were whole natural foods. And they said, eat what you want. And then at the end of 2 weeks, they switched the two groups. And the trays were all matched for calories and macronutrients, and sugar and sodium and fiber. So they were just told, eat what you want. So what they found was the group that ate ultra-processed foods consumed 508 calories on average more every day. And that was associated with a 2-pound weight gain for each of the groups. So when they were in the whole natural foods group, they lost 2 pounds for over 2 weeks. When they were in the ultra-processed group, they gained 2 pounds and ate 500 calories more with ultra-processed and less with whole natural foods. And what they found also was that that increase in energy consumption or increase in calorie consumption came from carbohydrate and fat, but not the protein. So this is a picture of the ultra-processed breakfast, which it kind of looks like a normal breakfast. So Eggo pancakes, some margarine, Smucker's syrup, turkey sausage, tater tots, and apple juice with some added fiber supplement. This is an ultra-processed lunch. So deli turkey, American cheese, mayonnaise, white bread, baked glazed potato chips, which we all think are healthier than the regular ones, right? Peaches canned in heavy syrup, vanilla non-fat Greek yogurt with that fiber supplement added, and then Crystal Light with a fiber supplement. So this is the whole natural unprocessed breakfast. Eggs, hash brown potatoes, some spices, cream and onions, salt and pepper. And this is an example of an unprocessed lunch. So a salad with some whole grain and some chicken and a vinaigrette made from fresh lemon juice, apple cider vinegar, and olive oil.
No sandwich.
What's that?
No sandwich.
No sandwich. So the American Heart Association and American College of Cardiology came out with new dietary guidelines, sort of saying let's steer away from the low-fat thinking that the government put out in 1977. And the recommendation now is to increase the healthy fats in our diet, the polyunsaturated fats. So things like avocado and olive oil and nuts that grow on trees, which is basically every nut but a peanut, right? It's not that peanuts are unhealthy, but when we use that term tree nuts, that's what we're talking about. Shellfish even, and the fatty fishes, those are all really good fats. So fat intake, just to be clear, does not correlate with weight gain, even though it has more calories per gram. And multiple studies have now demonstrated that the quality of the food seems to be the most important factor for health, for overall health, meaning whole, natural, unprocessed foods and avoidance of sugar. So, just to finish about the fat intake, this was a meta-analysis, 21 prospective studies, including nearly 350,000 patients over up to 23 years. And in all of those patients, the intake of saturated fat was not associated with an increased risk of coronary disease, stroke, or any type of cardiovascular disease. So there really is no good evidence that a low-fat diet confers any cardiovascular benefit whatsoever. And what we know from that earlier slide is if we reduce the fat in our diet, something else is going to come up, and that's usually carbohydrate. So there's no significant evidence for concluding that dietary saturated fat is associated with an increased risk of cardiovascular disease. Doesn't mean I want you to all eat burgers and bacon, by the way. Didn't ask that before. All right, so let's talk about sleep. Sleep is very tightly linked to weight. At short sleep of less than 5 hours a night, there's a 30% increase in overweight, and there's a 200% increase in obesity. And that's all driven by substantial hormonal changes that I'm going to go over. So in the 5 to 6 hour range, there's a 20% increase with overweight and 57% increase in obesity. And you can see the difference in sleep over the years. In 1960, the average American got 8.5 hours of sleep. In 2009, that was down to 6 hours and 40 minutes. And 1/3 of adults in our country sleep less than 6 hours per night. So this was a study of over 1,000 participants, and those who consistently slept only 5 hours as compared with those who slept 8 hours. There's a 14.9% increase in ghrelin. Ghrelin is our most powerful hunger hormone. It acts on our brain to make us eat. So when we feel starving, that's not happening in our stomach, it's happening in our brain, and that's ghrelin. So 15%, essentially a 15% increase in how hungry we are all day long if we get 5 hours of sleep. And a 15.5% decrease in leptin, which is our most powerful fullness hormone. And a 3.6% increase in body mass index on average for those who only slept 5 hours.
Does this include naps during the day?
So that's a good question. That hasn't been studied, but what has been studied is that napping more than about 20 or 30 minutes does not prove to be beneficial for a lot of other things, for the missed sleep at night. So if people take long naps during the day, like 1 to 2 hours, that doesn't seem to make up for the lack of sleep at night. But short little cat naps have been shown to have some benefit. All right, so let's talk about the joints. Patients who suffer from obesity tend to require hip replacement on average 10 years earlier than patients who don't have obesity, and total knee replacement 7 years earlier. And weight loss of 7.5% or more has been associated with reduced risk of needing knee replacement. Weight gain of just 5% body weight increased the need for hip replacement. Increased weight is also associated with increased risks around knee and hip replacement. So increased risk of wound complications, infection, hip prosthesis dislocation, as well as DVT, deep venous thrombosis. And Medicare, in fact, won't pay for a hip replacement or a knee replacement if the body mass index is greater than 40, because the risk of infection is double. So that's why if any of you ever needed a hip or knee replacement, your doctor may have talked to you about weight. All right, so why is it so difficult to maintain weight loss? Everybody knows that there's a cycle. You lose weight, you tend to regain the weight. You lose the weight, you regain the weight. It's very difficult to keep weight off. So in fact, only 1 in 6 people who lose 10% of their body weight or more will keep it off. So you can see these are, as the blue bars get smaller, that's how much weight these people lost, with the smallest bar being 20% or greater. So less than 5% of people can maintain 20% weight loss or greater. And in fact, 94% of people who lose 10% of their body weight or more will regain all of that weight within 1 year. Now that's historical data before sort of the evolution of more acceptance of weight loss medications, which I could talk to you about as well. So this was a landmark study in the New England Journal of Medicine in 2011. They took people and had them lose 10% of their body weight on a calorie-restricted diet, and they measured, they had them rate their hunger level and their desire to eat at the beginning of the trial before they ever lost weight, 10 weeks after achieving 10% body weight loss, and then a year after that. So the black line is the beginning of the trial before they ever lost weight. You can see where they rated their hunger, that's that top graph. And by the way, this is postprandial time, 0 up to 4 hours. So immediately after a meal, that's where they rated their hunger level. The blue line is 10 weeks after achieving 10% body weight loss, and the red line is a year after that. So even 62 weeks after achieving weight loss, these subjects still reported feeling hungrier than they ever did before they started losing weight. And the same is true for the desire to eat. Feeling more desire to eat after weight loss. And that is because of several substantial hormone changes. So hunger and satiety, hunger and fullness, are dictated by hormones that act on our brain. So in the top left, that's ghrelin, that's our most powerful hunger hormone. And again, the black line is before losing weight. The blue line is 10 weeks after achieving 10% body weight loss. Ghrelin level is substantially increased all day long. And even the red line is 62 weeks after achieving weight loss. We're still hungrier than we were before we started losing weight. The other 3 squares are 3 powerful satiety hormones or fullness hormones that tell our brain when we feel full and satisfied. And so again, the red line is 62 weeks after achieving weight loss. We're still less full and satisfied, even immediately after a meal, than we were before we started losing weight. So we're hungrier and we're less full. And this is all, by the way, in an effort to protect us from starvation. The third major adaptation to weight loss is called adaptive thermogenesis, which is a big fancy term for a change that happens in our skeletal muscle that basically makes our skeletal muscle more efficient, which sounds like a good thing. It's okay, but what that means is that our skeletal muscle undergoes a change to conserve energy and to burn fewer calories for the same work we do. So if one of us goes out and lives an entire day, including an hour of exercise, active, run errands, whatever you're gonna do, and then you lose 10% of your body weight, and then you live that exact same day, just by virtue of having lost weight, you are going to burn 300 to 350 calories less after losing weight, just because you've lost weight. So you're burning fewer calories, you're hungrier than you were before you started losing weight, and you're less full and satisfied. Let's see if I missed anything. Oh, these changes, by the way, have been shown in some studies to persist out to 6 years post-weight loss. So, how can we achieve and maintain weight loss? It really takes a comprehensive approach. It is not just as simple as telling somebody to eat less and move more. If it were, it'd be easy, right? It's much more complicated than that. So the highest success rates for weight loss and more importantly for maintenance of weight loss are seen in a physician-led program with a minimum of 14 visits in the first 6 months and 22 visits a year, which by the way is why Medicare will cover exactly that many visits for weight loss. Nutritional counseling, gradual exercise goals, and pharmacotherapy, so medications to assist with weight loss. And the medications to help with weight loss are FDA approved for a body mass index of 27 or greater with at least one associated condition: high blood pressure, diabetes, arthritis, multiple cancers, anything that can be associated with obesity counts as a comorbidity, or a body mass index of 30 or greater. So the three most important predictors of maintenance of weight loss are 420 minutes of exercise per week, which I realize sounds daunting, but you can think of that as 4 15-minute walks. So from a weight loss standpoint, the goals are different from cardiovascular fitness. So we're not talking about getting your heart rate up and sweating and keeping your heart rate up for 20 or 30 minutes and then gradually letting it come down. We just want to burn calories. We want to burn that 350 calories that we're no longer burning because we lost weight. So 300 to 350 calories comes out to about an hour a day of physical activity. So you can think of that as 4 brisk 15-minute walks. Some form of self-monitoring, which can be a daily weight, or food journaling, or using one of the many apps. You know, MyFitnessPal is what we recommend in the weight loss clinic, but there are multiple apps where you can keep track of your calorie intake, and your carbohydrate intake and your protein intake. And then ongoing face-to-face encounters with somebody who's trained in weight loss. So those three things increase the success rates of maintenance of weight loss. So this is just a table of some of the, well, not some, this is essentially all of the weight loss medications. So you may have heard of Ozempic and Wegovy and these medications. They've been all over the news over the last year. The reality is these medications have been around for a long time, like 20 years. They've just evolved and gotten better. So liraglutide, semaglutide, and tirzepatide are in the GLP-1 category. The semaglutide is Ozempic and Wegovy. Mounjaro is Zepbound, and then liraglutide is Victoza and Saxenda. These medications are 97% bioidentical to a natural substance we all have called GLP-1, glucagon-like peptide 1. Glucagon-like peptide 1 stimulates the place in our brain that makes us feel full, feel satisfied. So you give yourself a little pin clicker injection once a week. It stimulates the place in your brain that makes you feel full, so it suppresses hunger. It also slows the movement of food through our stomachs. So for people who struggle with portion control or feeling hungry within a couple hours after eating, it's extremely beneficial for those people. It also lowers our cardiovascular risk. So semaglutide was the first one to get the FDA approval for cardiovascular risk reduction for patients suffering from overweight or obesity. And Medicare has picked them up. We're finding, it's just been about 2 months, so we're finding we're getting it approved for some patients, not approved for other patients, but that's only gonna get better. So it reduces our cardiovascular risk and improves our insulin sensitivity. These are the best medications to come around since statins. Bupropion and naltrexone is an entirely different medication. The brand name is Contrave. It's a pill, not an injection. It's a daily pill. Naltrexone and bupropion both stimulate the place in our brain that deals with cravings. So bupropion is Wellbutrin. It's also FDA approved for smoking cessation because it reduces cravings. So Contrave is not as much of an appetite suppressant as it works on eating for other reasons. Emotional eating, stress eating, boredom eating, sweet cravings, salty cravings, that kind of thing. And then Phentermine, topiramate. Phentermine's been around since 1959. It was half of the old Fen-Phen that got pulled off the market. Fenfluramine was the one that could cause heart valve problems. Phentermine does not. It's still on the market. It's a stimulant, and so through its stimulant effect, it suppresses appetite. Topiramate is Topamax. It's been around forever to treat migraines and seizures. Long been known that one of the most common side effects of topiramate was weight loss. So now it is available in a very low dose, long-acting combination pill called Qsymia that's FDA approved for weight loss.
What's the name of it?
Qsymia.
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 You buy it over the counter, or you have to?
No, it's prescription, and actually Phentermine's a controlled substance, so you can only do 30 days at a time. 30 days with no refills, but you can keep getting it. That's it. Did I do 30 minutes?
When you take these medications, is it long-term or do you back off of it?
Yeah, that's a good question. So the question is, should the medications be long-term or can you back off? They really should be long-term. That doesn't mean they have to be forever, but remember those changes that I talked about have been shown to last up to 6 years. So if you think about those physiologic adaptations to weight loss, if somebody just wants to take medication for 6 months, get some weight off, and then they stop the medication, well, their hunger hormone's higher than it ever was before they started losing weight, and their satiety hormones are suppressed, and they're burning fewer calories, so we get back to that same problem, right? So eventually the body, we believe, does sort of reset and say, okay, this is my new weight, but that takes several years.
And y'all raise your hands and I'll get the mic to you.
I have 2 questions. The first one is alcohol consumption and weight. The second one is a bit different, and that is I gained my most weight when I was traveling across time zones 2 or 3 times a week. And that seemed to be a possibility of a weight gain. So I don't know if that's been studied or not.
That in particular hasn't been studied to my knowledge, but my guess would be that you weren't getting as good a sleep and you may have been eating more restaurant meals if you were traveling that much. I don't know if that's true, but traveling across time zones, often we're jet lagged and maybe don't get enough sleep, but those 2 things will add weight. If you think about how many meals out people eat now, typically restaurant meals. When I was a kid, my mom is here. When I was a kid, we ate out for special occasions. So on your birthday, you got to go out to eat. And now people eat out, every day. Sometimes all their meals, sometimes several times a day. And restaurant meals are larger portions, and they tend to be lower in protein and higher in carbohydrate because it's cheaper. And to your first question, the alcohol, the main issue is calories. If you're doing something, if you're drinking craft beer or sugary cocktails, then you have to also worry about carbohydrate. But the main thing is it's calories. So what I tell people in our program is this is meant to be a sustainable way of living, right? Our goal in our program is to find a way people can live and be happy, but be at a weight that makes them happier. So it's not my job to come in and say, I need you to stop drinking alcohol. But if you want to spend 300 of your calories on alcohol, then you don't get to eat those 300 calories. So it's just a budget like anything else.
How do you suggest working with this, with the diet and all, when all of us are elderly and we live in this community where our meals are prepared And we have certain times of the day to eat. And we have some, there's variety, but some limited choice in the kinds of vegetables and fruit and the things that we can eat.
Yeah, it does make it more difficult, I think, when you have so many options. It's basically like eating out for every meal, right? There's lots of options. I have had patients move to very nice living facilities like this and put on 40 pounds because they had dessert after every meal, and they didn't used to do that at home. So I encourage patients who don't have the options of making their own food to try to stick with protein and vegetables for most of the meals. And we're not low carb, I'm not a low carb person, but you just wanna do healthy carbs. So you don't wanna, you wanna try to skip the chips. If you're doing bread, try and do healthy bread and limit it to the bread you'd get on a sandwich. You wanna limit fruits actually to probably 2 servings a day. Don't do 3, 4, 5 servings of fruit per day, because that's a carbohydrate. So if you can stick with protein and vegetables as much as possible and skip the desserts, that's a good start.
Have you looked at Westminster's menus?
It's been a long time. It's been a long time. I had patients, so we've been doing the weight loss program for about 7 years, about that. And in the very beginning, I remember I looked at some menus, but I haven't in a while.
Along with that, the food seems to have a heck of a lot of salt.
Okay.
I'm saying that the food here has a heck of a lot of salt in it.
Okay. So the salt doesn't add weight unless you have a tendency to retain fluid, and that's water weight. So it's not gonna make you gain actual body fat weight, but yeah, not so good for blood pressure, it's not so good for retaining fluid.
Then I have another question. What about what happens to you when you were a child when people made fun of you because maybe you weren't overweight, but you were bigger than others?
Yeah. So there's a tremendous amount of emotional trauma associated with kids who grew up teased or bullied or overweight or suffering from obesity. And we have to, we don't have a psychologist or a psychiatrist or a therapist who works with us, but there are some in town. But yeah, it's definitely a factor. It can be very damaging. It can even promote PTSD depending on how aggressive the parents were with criticizing the excess weight. And there are a lot of genetic conditions, by the way, that predispose for weight gain. In one series of patients undergoing bariatric surgery, weight loss surgery, 70% had a genetic mutation that basically makes our receptors less sensitive to leptin, which is the most powerful satiety hormone we have. So people who suffer from that just don't ever feel full. Any other questions?
Is this on already? Can you hear me?
Yeah.
I'm a kind of a fan of Robert Lustig at UCSF. I'm sure the endocrinologist is there. He seems to think most of these metabolic diseases are caused by excess consumption of sugar, particularly the fructose component of sugar, which can cause fatty liver disease. Do you have any opinion on that? And many researchers think we are evolutionary addicted to sugar.
Oh, we are absolutely addicted to sugar.
And is it just as addictive as cocaine? Except cocaine will kill you quicker and take decades for excess sugar consumption to kill you. Do you have any thoughts on this from your?
I do. So sugar is actually 8 times more addictive than cocaine or nicotine.
Wow.
And so if you think about from an evolutionary standpoint, if food is scarce, what would benefit us to go for the quickest energy we possibly can, which is carbohydrates, sweet things, right? So we were genetically evolved to seek out sweet things, including fruit and sugar.
Well, there's all, I just mentioned, I think I mentioned that on the
I can hear you.
microphone, is that prehistoric man, when he tasted something sweet, it was usually identified as not being poisonous. So that's.
Interesting, I hadn't heard that.
What
Yeah,
was
that's
that again?
interesting. He said that he understood that prehistoric man, when they tasted something sweet, it indicated that it wasn't poisonous. So just another reason that we were trained to seek it out. Did you make your question?
Just wondering about the connection between sleep and weight gain. If you chronically get.
Can't hear you.
If you chronically get less sleep than you should, like severely less, that makes you gain weight regardless of your diet at that point?
Yes. So, the question is about how sleep impacts weight, and this is, and again, it's something a lot of people don't know. So not only are there changes in hunger hormone and satiety hormone, but at less than that critical 5.5 hour sleep per night mark, there's a substantial increase in stress hormones. And stress hormones are essentially like being on prednisone. It's cortisol, insulin, glucose, all the stress hormones. And that's really where that weight gain comes in. And then again, if we're hungry, we're gonna eat. We're hardwired to eat when we're hungry. So if you have a 16% increase in your hunger hormone, chances are you may consume 16% more calories, even if you're not realizing it. Just little snacks and things here and there, and portion control. You were next.
What about the experience when you were so skinny as a kid growing up, you were encouraged to eat as much as you could, and you could eat everything and not gain an ounce? And then all of a sudden you hit 20. And things started sticking to your ribs that wouldn't stick before.
Yeah. So unfortunately, I don't have a solution to that, but I have a bit of an explanation. After our 20s, we start losing muscle mass. So by the time we reach 80 years old, we've lost 30% of our muscle mass, most of us. For every 1 pound of muscle we lose, we knock 20 points off our metabolism, because muscle burns more than any other tissue. So if you eat the same way from your 20s through your entire life, you are going to gradually gain weight. Unless you're actively working to put on muscle, which gets harder and harder as we get older.
What has been your experience with the Ozempic and the various other weight loss?
Yes, so they're great medications. Like I said, they are really the best medications, in my opinion, to come around since statins. And they're not new. Important to know that just because the media knows about them now, doesn't mean they're new. The original drugs in that class are 20 years old. Victoza is 17 years old. Ozempic is 8 years old. So these medications have been around. So they are tested, and you know, there's no surprises with them. But because they're 97% bioidentical to a natural substance, they don't interact with any other medications. They lower cardiovascular risk. In about a year, we anticipate the FDA is going to give them the indication for treatment of fatty liver. They've been implicated in reducing dementia, reducing kidney disease. So all these things we see increase with increasing weight, they are helping to reverse that through almost like a natural mechanism. And the other medications are good too. They have not been studied for the cardiovascular risk reduction, so we don't know if it's a class effect, meaning it's something specific to those medications, or is it just the weight loss? There is some evidence to suggest it's those medications in particular. We've seen people who drink heavily and are able to stop drinking alcohol on these medications because, again, it works on that place in the brain. So yeah, I think they're great. If we can get them covered. They're way too expensive, but when we can get them covered, they're great medications.
Can you describe, this may seem like a funny question, describe what it feels like to be hungry? Because I don't have a sensation where I feel hungry, but I eat because I feel I lack energy, and so I want something to put in my mouth to eat that I think will pep me up and give me more energy.
Yeah.
Is that one of the symptoms of hunger?
So that may be, yes, I mean, that could be a symptom of hunger for you. And there are other mechanisms that can drive people to eat more than their body may need, right? So sometimes, like I said, it's emotional eating or stress eating or boredom eating or just that the food tastes good or that you want that energy. In terms of energy, oftentimes we take a closer look at the carbohydrate intake. Because what happens is if you eat a high carbohydrate meal, your insulin is gonna go up steeply and quickly. And that then is gonna pull that fuel right out of your bloodstream, and that's gonna leave you feeling tired and depleted and hungry again. So there's this carbohydrate insulin model that really blames a lot of the obesity epidemic on that specific fact. That the more carbohydrate you eat, the hungrier you are. And the more you want to eat.
Does good sleep have to be continuous?
So somebody asked about naps earlier.
Well, I mean, I don't nap, but I don't sleep.
No, it does not need to be continuous. The goal on sleep is at least 7 hours. If you can just get 7 hours of pretty good sleep,
But if you get up to go to the bathroom.
yes.
Yeah,
Lots of
getting up
bathroom
and
breaks
going
is
to the
fine.
bathroom's okay, right?
Yes,
Okay.
yeah. Just get back to sleep. Total 7 to 8.5 hours is the sweet spot for weight.
Is that it? Thank you so,
Sure.
so much. This is wonderful. You all should have brochures about the program at Austin Hart. You also have evaluations to fill out and leave at your chairs or give back to someone in the wellness committee. And thank you so much for showing up. Every single time we have a presentation, I get nervous. Because we're asking a very famous person in the medical community to come share their wealth of knowledge with us. So thank you all so much for showing up, and let's give one more hand of appreciation.